This is the elimination review. BPH, benign prostatic hyperplasia, BPH treatments. We have medications, alpha blockers, tamsulosin, Flomax, 5-alpha reductase inhibitors, finasteride, Proscar. TURP is a transurethral resection of the prostate. It's the most widely used procedure for prostatic gland removal. We only do this after medications don't work. So your TURP assessment, go into your PowerPoint and use this little diagram. So with a TURP, afterwards we're going to have a continuous or intermittent bladder irrigation. We need to closely observe the drainage bag. We want to look for bladder distension. If the bladder is distended, the irrigant and the urine might not be flowing. You need to check that catheter for kinks. Excuse me. We want to assess, and bladder distension can cause pain and bleeding. We want to maintain that catheter patency. We're watching for bladder spasms, pain control, analgesics, and decreased activity for the first 24 hours. Avoid straining with BMs, increase fiber and laxatives. Complications, bleeding should gradually decrease to a light pink in 24 hours. A few hours after, you may have some clots and it may be darker in the bag, but that's expected, and should gradually decrease to light pink in 24 hours. To avoid urinary incontinence, the patient will do Kegel exercises, increase fluids to decrease infections, and prevent DVTs with sequential compression stockings, low-dose heparins, and discourage sitting for prolonged periods of time. Causes and prevention of constipation. So causes are immobility, bed rest, low fiber foods, chronic laxative use, depression. Preventing constipation, you want to be active, eat a lot of high fiber foods, drink a lot of water. Foods associated with constipation. High fiber foods decrease constipation. So you want to eat a lot of foods that are high in fiber, fruits, vegetables. Foods that increase constipation include dairy products such as cheese and milk, white bread, bananas, fried foods, and foods low in fiber. Colon cancer screening. The U.S. Preventative Services Task Force recommends that adults start occult blood testing, sigmoidoscopy, or colonoscopy at the age of 50. GI tract, just know that most of your absorption takes place in the small intestine. So iodine and latex cross allergies. For iodine, you're going to not use the iodine that typically comes in your Foley catheter kits to cleanse your patient because of that possibility of a cross allergy. You're going to use chlorhexidine. For latex catheters, you would substitute it like with a silicone catheter. So furosemide, it's a diuretic. We need to remember to give it in the AM to prevent nocturia or the patient getting up to urinate at night. Preventing urinary elimination problems, encourage adequate hydration. So encourage adequate hydration. Empty the bladder with first urge. Completely empty the bladder. Maintain normal body mass index. Refrain from smoking. Avoid caffeinated beverages. Maintain regular patterns of elimination. Aging in elimination. May urinate more frequent. Oh man. So aging and changes in elimination. May urinate more frequently due to the amount of urine in the bladder. The amount of urine the bladder holds reduces. Incontinence is not a normal part of aging, but it may occur because of mobility problems or neurologic impairment. Renal blood flow reduces, but it does not impair the bladder's ability to produce urine. Full urinary control occurs at 4 or 5 years of age. And in infancy, urinary control is absent due to neuromuscular immaturity. Those last two statements are true, but like if you were going to like a senior center or like an assisted living facility or somewhere where you were doing teaching for older adults, it's not really necessary to teach them about the 4 and 5 year olds and urinary control or the infants and urinary control. Aging and changes in the urinary system. So we do know the amount of urine in the bladder or that the bladder can hold reduces. So this might increase frequency of urination. Dementia is not a normal part of aging, but dementia can cause the patient to lose sphincter control. Incontinence refers to the loss of control of either urine or bowel elimination. When referring to incontinence products, we want to call them underwear or briefs, or by the brand name, you might want to call them like Depends. We don't call them diapers because this could affect the person's self-esteem, or it could be like a dignity thing. Incontinence and tissue integrity. We want to clean our incontinent patients as soon as possible so that we prevent or reduce the possibility of skin breakdown. Preventing UTIs in general. Encourage adequate hydration, emptying the bladder with first urge, and emptying the bladder completely. And that's just so we don't have urine sitting in the bladder growing bacteria for a prolonged period of time, just to get that urine out. Maintain normal body mass index. Refrain from smoking. Avoid caffeinated beverages. Maintain regular patterns of elimination. Females wipe from front to back, and avoid bubble baths. And you'll see that I X'd out the modifiable versus non-modifiable risk factors for UTI. Preventing UTIs in catheterized patients. Keep stool away from insertion site or the urethra. So we want to make sure, like if you have an incontinent patient who also has a Foley, like if they're incontinent in a stool, that you do everything that you can to avoid stool going into that urethra to prevent a UTI. We want to keep the bag below the bladder. So the patient, like if they have a leg bag, they want to keep it on their leg, just whatever they need to do to keep it below the bladder. They don't want to like hang their Foley bag higher than their bladder while they're doing things. Use sterile technique when inserting. Always use sterile technique. Always use sterile technique when placing a Foley catheter. Give appropriate and thorough perianal care. Hygiene of the genital region. Assess equipment carefully to ensure a closed system. And intervene to prevent prolonged catheter use. And bladder scanners have eliminated the need for in and out catheterization. Signs and symptoms of a UTI: an elevated white blood cell count, urine with a pungent odor, increase of sediment in the urine, confusion or alteration in mental status, a change in urination pattern. So, and assessing for fullness, or I'm sorry, retention. The patient might have a feeling of fullness. The bladder may be distended, abdominal pain or discomfort, and you could use a bladder scanner to see how much urine is in the bladder. So know your types of incontinence. This is copied and pasted from your PowerPoint. Stress incontinence, leakage or a small amount of urine during physical movement such as coughing, sneezing, exercising. Urge, leakage of large amount of urine at unexpected times, including during sleep. Overactive bladder, urinary frequency and urgency, with or without urge incontinence, functional, untimely urination because of physical disability, external obstacles, or cognitive problems that prevent a person from reaching the toilet. Overflow, unexpected leakage, or a small amount of urine because of the full bladder. Mixed, usually occurrence of stress and urge in incontinence together. Transient, leakage that occurs temporarily because of a situation that will pass. Infection, taking a new medication, cough with cold. Hematuria, blood in the urine. The most common causes are mechanical injury of the urethra, urinary calculi, genital urinary cancers, UTI, pyelonephritis, infection of the kidneys, glomerular nephritis, infection of the glomerular structures of the kidneys. Be able to list causes of hematuria. What do you do if the catheter goes in the vagina? Leave it in place and get a new one, a new sterile catheter. And just the rationale behind that is if it goes in the vagina and you leave it there and you go up or higher up to insert the catheter, you're not going to go in the same place again. You're more likely to go in the urethra instead of in that same place again. Cleansing procedure for catheter insertion. For women, spread the labia with non-dominant hand to visualize the meatus. Do not allow the labia to close over the meatus. Cleanse in an anterior-posterior direction. And cleanse using one cleansing ball for each wipe downward. Cleanse lateral to center with the last wipe over the meatus. So know those anatomical terms. We're basically cleaning from top to bottom and from outside to inside. For men, grasp the penis just below the glans with non-dominant hand. Retract foreskin if necessary. Cleanse in a circular motion from meatus around the glans to the base. Use a new ball for each time for 3 more wipes. So that's a total of 4 wipes. You have the original one and then 3 more. If your kit only comes with 3 swabs or 3 cotton balls, make sure that you get like another package of cleansing swabs. You don't necessarily need to get a whole new kit, just another pack of swabs, because you don't need everything else in the kit, like the catheter or the bag or anything. You just need the swabs. Catheterization steps. Review your checklist for this. But here's a few things to kind of keep in mind or to emphasize on. If a catheter becomes contaminated by touching the labia on a female, foreskin on a male, or any other part before entering the meatus, performed catheterization with a new catheter. So if it touches anything, get a new catheter. Advanced catheter, 5 centimeters farther after urine flows through it. So once I get that urinary return, I'm going to go back like 2.5 to 5 before I inflate that balloon. So I just want to go a little bit more so that I'm not partially inflating that balloon within the urethra. Excuse me. Do not contaminate sterile gloves. Do not contaminate sterile supplies. So once I put my gloves on, I don't want to be touching the outside of the containers. And then I don't want to organize my supplies without sterile gloves. So I'm going to put my sterile gloves on after I've opened my kit, and then I organize my stuff in there. Like I open the swabs, or I take the little plastic protective sleeve off of the catheter itself. So I get all that stuff organized with sterile gloves. And I want to make sure I organize that supplies before I could. That says dominant, but what I meant to type was before contaminating the dominant hand. So you're that's worded badly, I'm sorry on that, but make sure that all your supplies are organized before contaminating your non-dominant hand. Catheter removal steps. Deflate the balloon completely before removing. You want to make sure that balloon is completely deflated so you don't cause any trauma to the urethra when pulling it out. Urine sample collection can be done when initially catheterizing the patient. When done using a closed indwelling system, make sure that you clean that needle-free port with alcohol before attaching the syringe to that needle-free port to withdraw the urine. Avoid breaking sterility during catheter insertion. If at any time the catheter touches anything before entering the meatus, make sure you get rid of it and get a brand new sterile catheter. Urinary catheter documentation. Date and time of catheter, the type and size. Was it a straight catheter? Is it indwelling? Is it condom? Is it suprapubic? The size of catheter. The amount of fluid used to inflate the balloon if it's an indwelling catheter. Urinary output, catheter patency, urine quality, quantity and odor, patient's alertness, orientation, abdominal assessment. So like before I put the catheter in, was their abdomen distended? Was it painful or uncomfortable to touch? The skin assessment, like was the skin around the meatus like intact? Was there irritation from a previous catheter? And any patient or family teaching that was done. So indications for a urinary catheter. So common indications for catheter would be like inability to void because of retention, like they can't physically get the urine out of their body. The need for close hemodynamic monitoring, somebody who's really, really sick and they need to know very, very specific urine output. And post-surgical recovery are all reasons for a person to need a catheter. Immobility or incontinence are not good reasons for a catheterization. It's introducing the possibility of a UTI when there's other ways to help those people get to the toilet or to meet their toileting needs. Bladder scanner is a diagnostic tool to detect bladder retention. It's placed on the bladder, you push the button, and it gives you an estimate of how many cc's or mils of urine are in that bladder. Female versus male anatomical risk factors for UTI. Women are at higher risk for UTI because compared with men, they have a shorter urethra and a shorter distance from the urethra to the anus. A shorter urethra increases infection because of the distance for bacteria to travel back to the bladder is shorter. Also, a shorter distance between the urethra and the anus increases the risk of fecal material and bacteria being introduced into the urethra. Men also produce an antibacterial substance within their prostatic secretions, which also helps reduce the risk for infection. So pregnancy and changes in elimination. Large volumes of urine because she has a larger blood volume during the gestation causes frequent urination. As the fetus grows, it puts pressure on the bladder, causing frequent urination. The use of prenatal vitamins with iron can contribute to constipation in the pregnant female. So if we encounter the problem with the pregnant female that doesn't want to take the prenatal vitamins because they are causing the constipation, just encourage fluids, fiber, and exercise. Autonomic dysreflexia. So we want to establish a bowel and bladder program for that patient to avoid constipation. So the autonomic dysreflexia, we're having this trigger where we're having a stimulus from the autonomic nervous system, and it's causing hypertension, bradycardia, severe headaches, pallor below the level of the injury, and flushing above the level of the injury. It can lead to convulsions, stroke, and death. So that autonomic stimulus is usually going to be a full bladder or constipation. So what we would do is alleviate that source. So if their bladder is full, like we would check their catheter for kinks to make sure that the bladder is able to drain fluid freely if they have a catheter. You would check a bowel. If you suspect constipation, you would check to see when the last time that person had a bowel movement. And alleviating the stimulus will usually alleviate the symptoms of autonomic dysreflexia. So elimination health history priorities, recent changes in elimination patterns, changes in color consistency or odor of stool or urine, discomfort or pain with elimination, and lists of medications taken by the patient. So that's what you want to ask in the health history. Those are your health history priorities. Anesthesia and elimination, just know that anesthesia can cause urinary retention. And it also can slow peristalsis and cause constipation. So that is everything that I have right now for the review. I hope this is helpful and helps you find anything that you may have missed on your own review. Please let me know if you have any questions.